Hi.
Good morning. Yeah, good morning, everybody.
Good morning, sister.
Yeah, please, how are you all?
We are
all fine.
Thank God. I'm also fine. Alhamdulillah, I'm also fine. Please, we are starting with the pelvis, the bony pelvis. Now we are having anatomy and physiology of the reproductive system. So let's quickly go through the pelvis, the bony pelvis.
Yes, please.
We have done the vulva. We know the vulva is attached to the pelvis. Yeah. So we are going to talk about the pelvis in general and then see how best we can identify the parts of the pelvis and then see how best we can describe it. I've given out the slide already. Please, I've given out the slide. So let's go through it. Whoever is having this, please, can somebody read for me? The bony pelvis. Please read. Once you read, I will explain it to our understanding. So go ahead and read, please.
Sister, please.
Yes, madam.
The bony pelvis is described as a basin-like structure situated at the lower end of the vertebral column, immediately below the fifth lumbar vertebra.
Okay. So I think that is the situation. If you can locate the pelvis, it is between the lower end of the vertebral column, and you can find it between the lumbar vertebrae. It is connected to the lumbar vertebrae. So let's see the functions of the bony pelvis first, before we talk about the divisions and then the other structures. Okay, so go ahead.
Sister, please, the functions is to receive the weight of the body, keep it balanced, and coordinate such balance by transmitting it to the feet.
So it means that it is the pelvis, your pelvis, that will receive the weight of your entire body. And then it will maintain that weight, then before it will transmit it to the leg. So that it means if you have any distortion in your pelvis, you are likely to have a widening gait. If you have any distortion in the pelvis, you are likely to end up having a waddling gait.
No, I can't see anything from the screen. I don't know it's from my phone.
Come again, you say what? What did you say? I didn't hear you well. Your line is breaking.
Please, I can't see anything from the screen. The slide, I can't see anything.
You're not?
Oh. Then maybe it's your network.
Oh.
But please, is it the same with everybody? Because somebody
please.
You can't see anything. Maybe I'm
Yes,
not sharing.
Yes, ma'am. Nothing on the screen.
So where is she reading from?
Please, they sent it to our group.
So they are not seeing my own, eh?
Yes, ma'am.
Oh.
Aja, please, have you projected your slide?
Yes, I've projected it too.
But we can't
I've projected it. You can see it.
Yes, please. We can't see the slide, but
so you can't see the slide.
Yes, ma'am.
Hey, then what is happening? Oh. Oh. Oh, what is happening?
Miss.
What's happening? Oh. Okay, now let me see if I can get the one on there. The network is started disturbing me again.
Mm-hmm. Mm-hmm.
I'm surprised that this thing is disturbing me. Please, can you now see?
Yes, ma.
Yes, sister.
Okay.
Yes,
Thank you.
sister.
Yes, ma'am.
Okay, thank you. Okay.
Thank you,
Okay.
ma.
Thank you, ma'am.
You're welcome. Okay, so let's continue, please. The one who was reading, can you go ahead and read? Oh,
Sister,
the person who was anybody at top. Okay,
Sister,
go
please,
ahead.
I'm reading. The
Okay.
second function, it
Mhm.
also functions by providing a cavity for the organs of the pelvis. Where such
Okay.
organs are, that one, please, I can't really see. Where such organs are supported and protected, sister.
Okay. So we are saying that with the functions of the pelvis, we are saying first, after receiving the weight of the body and then keeping it in position and making sure that the weight of the body is transmitted to the legs. And I was on the verge of saying that if you have distortion in your pelvis, then the possibility of you having a waddling gait, meaning that the way you walk will be distorted. Now, we also say that it provides a cavity for the organs that are situated in the pelvis. And what are these organs? Please, somebody should mention, one person should mention the organs that are situated in the pelvis. Pick one.
Sister, please, the innominate bones.
The innominate bone itself is the bone. And I'm saying what? The organs that are situated within the pelvis. What are these organs?
The uterus.
Uterus. Good.
Uterus.
Bladder. Good.
The bladder, uterus.
The vagina, the ovaries, the
The
fallopian
ovaries,
tubes.
the fallopian
Cervix.
tubes.
Good. Good. They are all situated in the pelvis. And so it is the pelvis that protects all these organs. Very good. Please go ahead.
Sister, the third one. It is
the
also
third
the
one.
bony birth. Sister, please. It is also the bony birth canal through which the baby must pass to be born.
Yes, it is through the pelvis that the baby must pass to be born. In fact, if you want to achieve normal vaginal delivery, then the baby will have to pass through the pelvis. Other than that, if it becomes abnormal, then the baby will be delivered through the abdomen, and that is cesarean section. I hope it is clear.
Yes, sister.
Okay.
Sister.
Let's continue.
The bony
Please continue
pelvis.
reading.
The bony pelvis is made up of the following bones. We have two innominate bones which guide the lateral and the anterior aspect of the pelvis.
Good.
So please, should I continue?
Continue, please.
One sacrum and one coccyx, which guide the posterior aspect of the pelvis. These four bones form a firm pelvic girdle, whose posterior wall is 3 times longer than the anterior wall. The bones are held together by
ligaments. Hello?
Yes, they are held together by a ligament.
By ligaments. They are held together by ligaments. So we are saying that the innominate bones constitute the formation of the entire pelvis. We have one sacrum, the two innominate bones, and then one coccyx. So we are going to see the structures that constitute the formation of the innominate bones. So when we are in the objectives, you see something like, which of the following structures constitute the formation of the pelvic girdle? You should know that there are 4 bones. There are 4 bones that constitutes the formation of the pelvic girdle. Now let's see the bones. We are saying that it is also, oh, who is this person? Who has started so early like that? My goodness. So we are saying that the bones are held together by ligaments. Had it not been the ligament, you see that the bones, whilst we are walking, will just fall apart. The symphysis pubis will open up. Then the sacroiliac joint, the stronger joints, will also open up. But because they are held together firmly by ligaments, it maintains the consistency and the structure and the strength of the pelvis. So let's continue to see. Please continue.
Please, I can't see the slide.
Oh, okay.
This is okay.
The innominate bone. Yeah.
The innominate bones. Each innominate bone is made up of 3 bones which are fused together. They are the ilium, the ischium, and the os.
Okay, so the os is supposed to be the os.
The ilium
os
is the upper external part of the innominate bone. It has a smooth anterior surface that is concave and is known as the fossa. It is for attachment of the iliacus muscle.
Iliacus muscles.
These form false pelvis and helps to support some of the abdominal organs. Also, it supports the weight of the gravid uterus where it arises out of the pelvis.
Good. So we are talking about the ilium. The ilium. We are saying that it is, I'm trying to get you the picture, the diagram of the pelvis, but I think. Oh, okay. I'm trying to get you this in the diagram of the. Okay. So we are saying that the ilium is the upper expanded portion of the innominate bone. And it has both anterior and posterior surfaces. It has superior and inferior surfaces. So we are going to see these structures that constitutes the formation of the ilium. Actually, the ilium forms the upper 2/3 of the acetabulum. It forms the upper 2/3 of the acetabulum. Please, do you have any question? Do you have any question?
Yes.
Okay.
Please,
okay.
I don't know. I read in Sylvia Verals that the innominate bone consists of the ilium, ischium, and the pubis. I don't know whether the os is the same as the pubis.
Os pubis. I said
Okay.
it's supposed to be os pubis.
Okay.
Os
Thank
pubis, yes. It's supposed to be os pubis.
Okay.
Okay. Os pubis. Okay. Please, do you have any question? I'm trying to show you the pelvis, so that's why I'm delaying. Let me see if I can show you the pelvis so that you understand it better. People will say, I'm not seeing, I can't see, and it will be delayed. That's why I don't want it to. That's what I do. Okay. Please, I'm showing the pelvis. Have you seen the pelvis?
Yes,
Please, can
sister.
you see? Very good. So this is the portion. This is the portion of the called the ilium. It is this portion that we are talking about as the flared out. Good. The flared out portion. You know, it has anterior surface, posterior surface, and then the inner surface, and then the outer surface. So we are going to see what constitutes or what is the attachment, the structure, the muscle, the type of muscle that is attached to the part that is called the iliac fossa. What is attached there? So please continue reading.
Sister, please. I can't see the slide.
You can't see the slide. Oh, yes. Sorry. Can you now see?
Yes, but it's where I read.
That's where you read
earlier. Yes, I've read that part earlier.
Okay. Go ahead.
Okay. The posterior surface of the ilium. The surface is rough and convex. Good. On it can be found the gluteal muscles.
Very good. So we are talking about, please, this is the posterior aspect. The posterior aspect of the ilium. It is convex and it gives attachment to the gluteal muscles. While the inner aspect is concave, you can see the concavity. It is concave and it gives attachment to the iliacus muscles. Please take note of that. I'm saying the inner aspect of the ilium is concave and it is for the attachment of iliacus muscles. Please, is that clear?
Yes, sister.
Okay.
Yes,
Once I'm having the pelvis, maybe I can go ahead and describe it so that we don't waste so much time. Now watch. The ilium has a crest. So this is the crest, the iliac crest. It has a crest which terminates anteriorly to form the anterior superior iliac spine. And about 2.5 centimeters below it, it forms the anterior inferior iliac spine. When you come to the posterior aspects, posteriorly, the bone terminates to form the posterior superior iliac spine. And about 2.5 centimeters below it is the posterior inferior iliac spine. And in fact, this posterior iliac spine, please watch, this posterior iliac spine marks the dimple that is behind every woman. You see, when you stand in a mirror, you can see two dimples. That marks the end of the posterior superior iliac spine. Okay. Any question? Any question, please? Yes, somebody, Mercy also, I can see your hand up. How may I help you? Come again.
Sister, please, I didn't see. Please, I can't see the video. I didn't see the video.
Okay. Cool. Okay. Okay. Please, can you now see?
No, please.
No,
That's why I
sister.
didn't want to show this. Others will see, the rest will not see, and it will cause a lot of delay. That's why I didn't want to bring it up. I thought you know it. You can now see it.
Yes.
Okay, better. So I'm talking about the iliac crest. I'm saying that
Please,
above
me, I
the
can't see, man.
this I
Sister,
can't see, I
please,
can't
me,
see
I
it.
can't see.
That is why I didn't want to bring it out. You see, I delayed in bringing it out because some will say they will see, others will say they are not seeing, and it will delay
Mama,
so much. Please, can you now see?
Mama,
Yes.
lower your
Yes,
Can
so
you now
No,
see?
no, please.
Hey, I'm somewhere.
Yes,
You can
sister.
see this one too.
we
We
can
can
see.
we can see. Ajia, we
Ah,
can see.
We can see.
let me quickly describe the pelvis so that we don't waste so much time there. Please, so this is the iliac crest that I'm talking about. And you can palpate your own iliac crest when you make an attempt to touch your hip bone. You can feel the iliac crest. No matter how fat you are, the iliac crest, once you palpate, you can still feel it. And that is the iliac crest. We are saying that it terminates anteriorly to form the anterior superior iliac spine. It is for pelvic, its function is to help with measurement of the pelvis, external measurement of the pelvis using what we call calipers, using the caliper. That is where you place it, and then you measure the adequacy of the pelvis. Okay. Now, the ilium also has a line, a ridge of bone. It has a ridge of bone. And this ridge of bone is called the iliopectineal line. Please, can you see? That's the iliopectineal line where I'm pointing at. That is the iliopectineal line. Both sides. It helps in measuring the transverse diameter of the pelvic brim. Please take note of that. The iliopectineal line, most of the measurement of the transverse diameter of the pelvic brim is taken between the two iliopectineal lines. Okay. Now, when you come in front of it, once you have the slide, later you can read, but I just want to describe minus without the slide so that you can clearly see it. Now, there's a thickened portion in front of the iliopectineal line, a thickened portion in front of the iliopectineal line, and that one is known as the iliopectineal eminence. In fact, when we are describing the pelvis, any portion, any part that you mention, let whoever you are describing to understand its function, its purpose of being there. The purpose for which God has made that thing there. Please, let whoever you are describing it to understand it. So talking about the iliopectineal eminence, it prevents morbid penetration. It prevents morbid penetration of the head of the femur through the acetabulum. It prevents morbid penetration of the head of the femur through the acetabulum. And this is the acetabulum. This is the acetabulum where the head of the femur is fixed into. And immediately behind it is the iliopectineal eminence. Please, I hope that is clear. Can I continue? Can I continue, please?
Yes,
Okay.
Yes, sister.
Good. I'm done with the ilium. I'm done with the ilium. So let's go
Sister,
to
please
the
take it again.
huh?
Please kindly take it again. The iliopectineal eminence.
Okay. I'm saying that the iliopectineal eminence is a thickened portion next to the iliopectineal line. That is it. And I said the function or the purpose of this iliopectineal eminence is to help prevent morbid penetration of the head of the femur through this acetabulum. And that is the acetabulum. It receives the head of the femur to form the hip joint. But then the iliopectineal eminence is taken behind it, so that when the head of the femur is fixed into the acetabulum, it wouldn't penetrate. It can't easily penetrate to get into the pelvis. Other than that, you'll be walking and then your head of femur will just enter and be hitting your bladder or whatever organ that is inside there. But God has made it in such a way that the thickened nature of the iliopectineal eminence will prevent the penetration of the head of the femur through the acetabulum. Please, that's what I say. Can I continue?
Yes,
Please, can I
please.
continue?
Yes,
Okay.
please.
Okay. Okay. Now, the ischium. The ischium. Please take note of the ischium. This is the ischium. It forms the lower 2/5 of the acetabulum, while the ilium forms the upper 2/5 of the acetabulum. Please take note of it. Wherever you meet it, don't get confused. Choose the right thing. I'm saying the ischium, this side. It forms the lower 2/5 of this acetabulum. The acetabulum is the yardstick, the point of reference. And so I'm saying that the ischium forms the lower 2/5 of this acetabulum, while the ilium forms the upper 2/5 of the acetabulum. Then the pubis forms the lower 1/5 of this same acetabulum. Please, is it clear? Is it
Yes, ma'am.
clear?
Yes,
Okay,
sister.
then
Yes,
let's
ma'am.
continue. Okay, so now the ischium.
Yes, sister.
Now the ischium.
Yes.
The ischium consists of a thickened area known as the ischial tuberosity.
Tuberosity, where the body
Yes.
rests.
Yes. So it has the thickened area that is the ischial tuberosity upon which the body rests when you are in the sitting position. So it's like if you are sitting right now, you are sitting on your ischial tuberosity. You see, sometimes, yes, sometimes when you sit for too long, you get up and it's like your buttocks is paining you. It's because of compression of the whatever you are sitting on. It's pressing your muscles against the ischial tuberosity. And so you get up and you feel pain. That's why it is advisable that you don't sit for too long. When you sit for some time, you get up and improve circulation, then you sit back. It's very important. Okay. So that is the ischial tuberosity. Now, there's another ridge of bone that
Take it again for me.
the ischial tuberosity.
Yes, please.
Okay, pay attention so that you can understand it. I'm saying that the ischial tuberosity is the thickened portion of the ischium. And I said it is the area, the portion that the body sits or the body rests on when you are in the sitting up position. And I'm saying that it has a ridge of bone. That is this side. It has a ridge of bone, this side of the bone, known as the ascending ischial rami. Ascending ischial rami, this one. So that is the ascending ischial rami. In fact, it is going to join the descending pubic rami. So that somebody will say, then there should have been a joint, but there's no joint there. Meaning the ridge of bone that you are seeing, this one. It is the ischial rami that is meeting the descending pubic rami. The ascending ischial rami joining the descending pubic rami, and with similar structure at the opposite side. Look at it. with similar structure at the opposite side. This one, you see, the pubic arc is formed. I'm saying the ascending ischial rami joining the descending pubic rami with similar structure at the opposite side. The pubic arc is formed and it should incline at an angle of 90 degrees. It should incline at an angle of 90 degrees. It is very, very, very important in midwifery because if the pubic arc does not incline at an angle of 90 degrees, it is going to cause perineal tear because when the baby's head is coming, it will get stuck. The head of the baby will get stuck. Something like this. The baby's head is coming. If the pubic arc is so acute, it's not inclining at an angle of 90 degrees, what will happen is that it will force the baby's head to pass through the perineum where there are soft tissue. It will force the baby's head to pass through the perineum and cause severe perineal tear, sometimes about 2nd degree tear or probably 3rd degree tear, because that is where the baby will feel comfortable. So do you know what the baby uses to cause the tear? It will use the chin. The chin, you know, is bony. So baby will use the chin to create a way, to create pathway to come out, because the subpubic angle is less than 90 degrees. And so it is not allowing the baby to feel comfortable to come out. It's like it is compressing on the baby's head. And so baby will be forced to pass through the perineum, hence 2nd or 3rd degree tear. Please, I hope it's clear. So that is the pubic arc. And the midwife, if you are a good midwife and you understand the anatomy of the pelvis, then you will definitely see that the woman is having subacute pubic arc. The angle is not 90 degrees. And so I wouldn't like this woman to deliver per vaginum. If I allow her to deliver per vaginum, she's going to end up with severe tear. Or probably that it may even end up with fistula, with rectovaginal fistula. I hope it's clear. So you should know by doing vaginal examination. When you do vaginal examination, what will let you know that this woman's pubic arc is too acute is that after vaginal examination, you know, when we did the VE, if you remember, when we started the labor, we mentioned it, that you place your hand here. Please, have you seen it? My 2 fingers can be accommodated under the pubic arc. It is so clear, it's so obvious. Don't tell me you can't see, because you can see. So you have 2 fingers. When you are bringing your hand out of the vagina, you turn your hand this way, so that if your 2 fingers can be easily accommodated under the pubic arc, it means the subpubic angle is 90 degrees. And therefore, it can allow the passage of the baby's head, for the baby can pass through that pubic arc. And it is, or it tells you that the woman is having adequate pelvic outlet. It tells you the woman is having adequate pelvic outlet. Some of the women, you see, when you make an attempt to position your hand this way, you realize that you can't, especially those with the android pelvis, unless you turn your hand this way. Unless you turn your hand this way, please, can you see? Unless you turn your hand this way, so that it is only 1 finger that is being accommodated instead of this way. Instead of the 2 fingers admitted, I mean the pubic arc admitting 2 fingers, it is rather admitting 1 finger. Then quickly, you should know that if you allow the baby's head to pass through vaginally, it will by all means make an attempt to make a cut through the soft tissues, the perineum, before it can be born, which is the biggest loss. You sit down and then somebody will say, we are now going to do bottomtailor. You are going to do bottomtailor, you have to suture. But if it is 3rd-degree tear, it has to be sutured by the obstetrician in theater. In theater, never, ever, as a midwife, make an attempt to suture a 3rd-degree tear in the delivery room. Please, you shouldn't do that. Else, it will end up with fistula for the woman. It should be done under anesthesia, and then the obstetrician will do that. Thank you. So we are still continuing with the description of the pelvis. I'm done with the pubic arc. It's so dear in midwifery, and that's why I've taken my time to explain it. Any question? Can I move on? Okay.
Yes,
So,
sir.
okay, better. Now, let's see the ischial spines. The ischial spines are situated behind the ischial tuberosities. Its significance in midwifery or in obstetrics is that the ischial spines divide the greater and lesser sciatic notch. Please, can you see the greater sciatic notch? Let me turn it this way. Please, that is the greater sciatic notch. Can you see that hole there? That is the greater sciatic notch. Yes, and this is the ischial spines, and this is the lesser sciatic notch. This is the lesser sciatic notch. You see, so the ischial spines divide the greater and lesser sciatic notch. In fact, the sciatic notches are for the passage of sciatic nerves. They are for the passage of sciatic nerves. And that is why, if you remember when you were doing your nursing, when they were teaching you how to give injection, we said divide the buttocks
into 4.
Divide the buttocks into 4 quadrants and give the injection at the upper outer quadrant. Why? Because if you don't give it at the upper outer quadrant, you are likely to enter into the sciatic notch where sciatic nerves are. And once you enter, you damage the nerves, the patient becomes paralyzed on that affected leg, the side that you are giving the injection. So you see the importance of the sciatic nerves. I mean the sciatic notch. Okay. Still on the ischial spine. Still on the ischial spine. This ischial spine. When it's protruded, its significance in midwifery proper. When it protrudes too inwardly, both sides project. Assuming this is the ischial spines of a woman. My fingers, please, can you see? My hands are on the ischial spines, but the woman's pelvis is, the woman's pelvis is that of the android. It's the android type. And so definitely the ischial spines are sharp. So look at my fingers as the extra or the length of a certain woman's ischial spines. Look at it. What is its significance? What do you think it can cause? Sandra and Triwa. Yeah, somebody has said it undertone. Say it loud. Whoever mentioned it, I heard it. Say it. Oh, don't worry. We are all sharing ideas.
Deep transverse arrest,
Very good. It will cause deep transverse arrest.
Yes, please.
It will cause deep transverse arrest. So that the head of the baby, that is the head of the baby coming. Now watch. You see, my fingers are the excess of somebody's ischial spines. See how it has arrested the head. Have you seen it? Please, have you seen it?
Yes, please.
Yes, so that is what we call the deep transverse arrest. And then it will delay second stage of labor. It will delay second stage of labor. But then you feel it. When you do vaginal examination, hello?
Please, can it also cause intracranial hemorrhage?
Yes, once it compresses on the head, especially in preterm delivery. Yes, it can cause if the pressure is too great. So that explains why we are saying that When you do vaginal examination, feel for the ischial spines. Feel for these ischial spines. If they are too sharp, you feel it. Despite that, it is covered with muscles. You can still feel the sharpness of it. Then it tells, sometimes somebody will say, it will even be pricking you. You do it and it's like it's pricking your hand, even though it is covered with muscles. Quickly, you should know that you should anticipate that there will be deep transverse arrest. And so don't allow the woman to deliver per vaginum. In fact, it will depend on the size of the fetal head. It will depend on the size of the fetal head. If you realize that even though the mother is having ischial spines that are projecting, but the abdomen is small, the fetal head is small, then she can deliver per vaginum. But if the head is big, then anticipate deep transverse arrest. And so why don't you let the woman deliver by CS instead of per vaginum?
Okay.
Okay. Is that okay? Can I move on?
Yes, please.
Very good.
Please.
Okay. And so I'm done with the ischium. I'm done with the ischium. Now the pubis. The pubis, there are two flattened portion of the innominate bone that forms the anterior wall of the pelvis. It forms the anterior wall of the pelvis. And because of the shortness, the short nature of the pubic bone, it makes the anterior wall shorter, measuring 4 centimeters, than the posterior wall, that is 12 centimeters. Please take note of that. The posterior wall is 12 centimeters, while the anterior wall is 4 centimeters. Okay. Now, the pubic bone. The pubic bone are two flat bones that are joined together. They are joined.
Sister, please, we can't see. The pelvis is down.
Yes. Thank
Is
you.
it now okay?
Yes, sister.
Yes,
Please take it
So,
again.
Yes, please.
okay, I'm taking it again. I'm saying that the pubic bone, these are the two pubic bones. This one and this one.
Yeah.
They are joined
take my
together.
glass.
Please stop that.
Yes.
They are joined together by a part of cartilage called the symphysis pubis. The two flat bones are joined together by a part of cartilage known as the symphysis pubis. The significance of the symphysis pubis is that most of the anterior measurement of the pelvis is taken from there. So the symphysis pubis is very, very important in midwifery. Let's see the superior aspect of the pubic bone. The superior aspect is called the pubic rami, superior pubic rami. So that's the superior pubic rami. The superior pubic rami joins the iliopectineal eminence. Please, you can clearly see. This is the iliopectineal eminence. This is the superior pubic rami, and it is joining the iliopectineal eminence. And I'm saying most of the pelvic measurements are also taken from the iliopectineal, it's taken from the superior pubic rami. Now, below the flat bone, that is the pubis, os pubis, we have the descending pubic rami. I've already spoken about it. We have the descending pubic rami, which I said will join the ascending or ascending ischial rami to form the pubic arch. If you remember, I just said it. Okay. So that is the pubic bone. Please, do you have any question? Please, do you have any question? Can I continue? Is it clear?
Yes, sister.
Okay.
Yes, sister.
Okay.
Yes, sister.
Now, good.
Sister, please, can you take the centimeters again? The 4 and the 12 you spoke about. I didn't get it.
Oh, I said the anterior wall of the pelvis is formed by these two flat bones. And you know they are short. So it makes the anterior wall of the pelvis shorter. whilst the measuring 4 centimeters deep. But the posterior wall is longer because it is also formed by the sacrum, which I'm going to talk right now.
Okay.
It's formed by the sacrum. So that one measures 12 centimeters.
Okay, thank you.
So it's like, yes, the posterior wall is 3 times longer than the anterior wall. Because if you divide 12 by 4, you see that it is 3. So it is 3 times than the anterior wall. Please, can I take the pelvis, the sacrum?
Yes, sister. Yes, sister.
Can I continue with the description of the sacrum?
Yes,
Yes,
sister.
Yes,
Papa.
sister.
So the sacrum, good. Now the sacrum, this is the sacrum. The sacrum. Remember, with any anatomical structure that you want to describe, make sure that you talk about the anterior, superior. You know, there are prefixes. There are prefixes and surfaces. When you enter nursing, they are the first things that they teach you. Anytime you go to any health training institution like midwifery or nursing, the prefixes and surfaces are something that they will teach you because you'll be using it throughout. Even at the master's level, you'll be talking about anterior, posterior, superior, inferior, medial, lateral. It will help you to describe any anatomical structure. So quickly, let's see the posterior wall of the pelvis. The posterior wall of the pelvis is formed by the sacrum. The sacrum, it is a triangular shaped structure. It is a triangular shaped bone. It is shaped like a wedge. A wedge is something that we use to crack or break firewood. Those hard metals, they are called wedge. And so that is how the sacrum is shaped. So let's start from the superior. We come to the inferior, we talk about lateral, then we talk about anterior and posterior. Then we are done with the sacrum. Please, the sacrum. Oh, who is doing this? Please, who is doing that? Pay attention, please. The sacrum, superiorly, the first sacral vertebrae joins the 5th lumbar vertebrae. So this is the first sacral vertebrae. This is the first lumbar vertebrae. So the first sacral vertebrae joins the 5th lumbar vertebrae to form the sacro-lumbar joint. To form the sacro-lumbar joint. It is a hinge joint. Now, the center of the first sacral vertebrae, this is what I'm talking about, this thing. The center of the first sacral vertebrae has a projection, a protrusion. It is projected inward. And that one is known as the promontory of the sacrum. It is called the promontory of the sacrum. So you can identify the promontory of the sacrum between the first sacral vertebrae and then the 5th lumbar vertebrae, where there's a projection. But then its significance in midwifery is that the promontory of the sacrum, most of the measurement of the pelvic brim is taken from the promontory of the sacrum. Therefore, when the promontory of the sacrum projects too inwardly, what do you think will happen? Please, somebody to answer for me. Hello? Hello? Go ahead.
It will obstruct labor.
It will obstruct labor at which level?
At the posterior to the
at the
that
brim.
the brim. Yes.
At the brim. Good. Yes. It will obstruct, I agree with you. It will obstruct the inlet.
The brim.
That's the brim. The brim is also known as the inlet. It is also known as the door. Please, I want you to take down these 2 points I've just mentioned. That's the brim of the pelvis. is also known as the door or inlet. So if the promontory of the sacrum projects too inwardly, it is going to reduce the anteroposterior diameter of the pelvic brim. So this is how it's going to be. That diameter, this is the diameter. It will just reduce it. To just reduce it and prevent the baby's head from entering. Okay. Now, let's see the inferior. We have spoken about the superior aspect. Let's talk about the inferior. Let's talk about the inferior. The inferior aspect of the sacrum articulates or joins the first coccygeal bone. It articulates with the first coccygeal bone, that is the coccyx, to form the sacrococcygeal joint. To form the sacrococcygeal joint. The sacrococcygeal joint, its significance in midwifery is that it normally tilts back, it moves backwards to increase the anterior posterior diameter of the pelvic outlet during second stage of labor. Is it clear? Are we together?
Please
Are
come
we
again.
together?
Andrea, please come
again.
again. Go over again.
Okay. I'm talking about the tip of the coccyx inferiorly. Oh, please, the one who is making that noise should stop. Assemble crying. Okay, so I'm saying that the sacrum, the inferior aspect of the sacrum, articulates with the first coccygeal bone so that it will form the sacrococcygeal joint. And I'm saying that its importance in midwifery is that this joint, the coccyx, tilts backwards at the sacrococcygeal joint. It will tilt, it will move backwards to increase the anterior posterior diameter of the pelvic outlet. It will, yes, come in. It will reduce the, it will increase the anterior posterior diameter of the pelvic outlet. Of the pelvic outlet, it will reduce the diameter. I mean, it will increase the AP diameter of the pelvic outlets. And if you remember, those of you who have been conducting delivery frequently, you're not getting to the second stage there. Apart from the contraction being intensive, you hear the woman complaining that her buttocks, her coccyx, they can't say the coccyx, but you will say, me too. It's like the buttocks is coming out. The rectum is coming out. They complain of severe pain there. It's all because of the coccyx trying to tilt back to give room for the baby to come out. You see, nature is so wonderful and we have to appreciate and understand him. So that is how come that the patient will be complaining of severe pain. And you, the midwife, if you don't know the anatomy and you don't know what is going on in the woman's body, you begin to shout at her. Don't shout at the client. She's actually suffering. So don't shout at her. If a whole bone is going back, it's not fracture, but it's moving backwards, how would you feel? So painful. So painful. So that is the anatomy of the tip of the sacrum. Now let's see the anterior aspects. Please watch the anterior aspect of the sacrum. It is concave. The anterior aspect of the sacrum is concave. You can see it's concave. And it is known as the hollow of the sacrum. The hollow of the sacrum. Let's see its significance, its importance in midwifery. We are learning the anatomy and applying it to our midwifery profession. So the hollow of the sacrum, its significance in midwifery is that because of the way it is curved, it helps to increase the AP diameter, the anterior posterior diameter of the pelvic cavity. Please take note of that. The hollow of the sacrum, because of the way it is concaved, it helps to increase the anterior posterior diameter of the pelvic cavity. Apart from that, the baby hides its face. Please pay attention. If you are not attentive at this time, try to be attentive, please. The baby, during second stage of labor, the baby hides its face in the hollow of the sacrum. The baby will hide its face in the hollow of the sacrum here. And remember, that is where the rectum also lies. The rectum lies in the hollow of the sacrum. And that explains why when the baby is coming, you will see that baby, feces will be coming out. That is, if you didn't manage the first stage of labor well. If you didn't manage the first stage of labor well, if the rectum was loaded, you did V, you felt it, but you ignored it. Instead of giving a warm enema to clear the rectum so that you can have a clean field to operate, you didn't do that as a midwife. And so when this baby is coming and is hiding the face in the hollow of the sacrum, it will clear any feces that is accommodating, that is, impacted in the rectum. The rectum is lying at where it is coming. And sometimes if the feces is constipated type, you see that the baby comes out and the face is bruised. Those of you in the delivery room, I think you'll bear me out. You see the baby's face, that beautiful soft tissue is having bruises. Where do you think the bruises is coming from? It's because baby was hiding the face there and there was constipated stool impacted there, and baby using the beautiful cheek to sweep it out. And hence the bruises on the baby's face. If it were to be your baby, would you like it? You wouldn't like it. So please, when they come and you conduct video and the rectum is loaded, for heaven's sake, if the cervix has not dilated up to 6 cm, give her enema, clear the rectum, and all this wahalatin will be the thing of the past. Okay. Any question? Yes, madam.
Please, I want to ask, if the woman is more than 6 cm dilated, can you give the enema to clear the rectum?
No, that's what I'm saying. If the cervix has not dilated up to 6 cm. So if it is more than 6 cm and you give the enema, what will happen is that the woman will go to the washroom, go and push it. Remember, the warmth of the water can also increase the uterine contraction. And so as she's pushing for the feces to come out, she will end up pushing the baby through a cervix that is not completely dilated. If it is the pit latrine, before you realize, baby is in the pit. So to avoid that, that's why it is recorded. Yes, it is recorded and it's accepted that don't give enema when the cervix is more than 6 cm. Because you give it in 4 hours time, she's going to deliver. You push the baby into the latrine.
So, Hadia, please, in this...
Hello,
please, in this... Hello. Please, Hadia, in this case, I mean, you did the V and there is a load in the rectum. How are you going to manage it? And the woman is entering the second stage of labor. Are you going to wait for her to empty it first as the first baby before you deliver the woman?
I like the way you said it. I like the way you said it. For it to come as the first baby. You midwives, I will address this thing before I can ask you, before I answer your question. It's so dear to me. So I will address it before I go to your question. She said, are you going to allow her to pass the feces to come out as the first baby? Please, midwives, fellow colleagues, you are my colleagues. Even though you are my students, we are all colleagues. Please, you should never, ever address feces as baby, as a first twin. You have so many names for that feces. What prevents you from saying that Give me tissue to clean the woman. She's passing feces. What prevents you from saying that? But you are rather coining a word. We are rather naming the feces as a baby, as a twin. Now there's a pending case in Kolebu, where a woman who has treated infertility for so many years, she has become pregnant. Precious baby. She came to deliver and she wanted vaginal delivery. She wants to get the feel of labor so that she can say, I've also delivered. Now she started pushing and then feces started coming because baby was pushing, using the face to clear the rectum and then pave way to come out. And they didn't know what the midwife said. She called the assistant. Please give me a tissue. The first twin is coming. First twin. So first twin, and then she cleared the feces. So after delivery, the woman says, where is my second twin? You gave me one baby. And I heard you saying first twin. And so wherever there's a first twin, there's a second twin. This is a big issue. It's a reality. I heard you midwife saying first twin. And I thank God I'm going to deliver a second twin. Meaning I'm carrying two babies. After going through this hardship of getting pregnant, God has given me two babies. And now you are telling me that I have one baby. No way. I won't accept it. So I'm telling you, as my students, as my colleagues, as junior colleagues or senior colleagues, please never ever coin the word baby by referring to feces. Please, is that clear? Is it clear?
Yes, sister. Yes, sister.
Yes, sister.
If you don't want any trouble, yes.
Yes,
Good.
sister.
You're welcome. If you don't want any wahala, you don't want any trouble, please call it feces. Let the woman know that she has passed feces and you are cleaning it. So please give me toilet roll. Toilet is coming. I want to clean it. So that the woman will appreciate you. She will appreciate you. Don't use any word in place of feces. Okay, let's move on. So I'm saying that I've spoken lengthy about the whole of the sacrum because of what it can create. Okay, so that is the hollow of the sacrum. I'm done with that one. Now, posteriorly, the posterior aspect of the sacrum is roughened, and it is for the passage. It is for the passage of. It is for the attachment of gluteal muscles. It is for the attachment of gluteal muscles. The muscles, those who are big buttocks, they are attached here. Okay. Now, let's go to the lateral side of the sacrum. Lateral side. Laterally, please, the one making noise, you better stop and let me teach the serious students. Who is making this noise? You. When I get you, I'll put you in the waiting room and then you'll be there till we finish the anatomy. Okay. So the lateral aspect. Laterally, the lateral aspect. Laterally, there are wings. And that is the wings I'm talking about, this one. What is the name of these wings?
Allah of the sacrum.
Good. Allah of the sacrum. The plural is Allah. Singular is ally. So we have the ally of the sacrum or the Allah of the sacrum. It is flat. It looks like a butterfly. Listen. It looks like a butterfly. It gives attachment. Its medial aspects. No, its lateral aspect. This is lateral, far from the midline. The lateral aspects articulates with the medial aspect of the ilium to form the sacroiliac joints. I'm taking it again. I'm saying that the ally of the sacrum laterally meets the medial aspect of the ilium, is the ilium, to form the sacroiliac iliac joint, and it is the strongest joint in the body. Please take note of it. The strongest joint you can find in the body is the sacroiliac joint. That is the sacroiliac joint. Is that clear? Now, let's see its importance. At least one importance is what I've mentioned. Now, in some women, congenitally, one of these Allah, one of them is missing congenitally. She was born without one of the Allah of the sacrum. And in that case, we call this type of pelvis as Naegele's pelvis. Some people will say Naegele. Can you identify the one making the noise? Please. Yes, some of you.
It's what happened. Why are you making noise like that?
What happened? Stop what you are doing. Stop it. Okay, let's go on. So I'm saying that congenitally, some people are born without one of the ally of the sacrum. And in this case, the name for this type of pelvis, without one of the ally of the sacrum, it is called Naegele's pelvis. Some people will say Naegele, but Naegele's pelvis is accepted. Naegele pelvis is also accepted. So Naegele's pelvis. And what will let you, the midwife, know that she's having one of the pelvis missing is through the way the person walks. Of course, she'll be walking with a waddling gait. She'll be walking with unstable gait, waddling gait. In some situations, both ally of the pelvis is missing. Both ally, this one and this one, are all absent. And in this case, we call it Robert's pelvis. We call it Robert's pelvis. Ladies and gentlemen, let me give you a clue that will help you to remember which one is the Naegele's and which one is the Roberts. I'm giving you a clue, just a clue that I used and it helped me. That is, when you remember the spelling of one. Oh my goodness. Please don't do this. Okay. So when you remember the spelling of one, it's O-N-E. And then when you remember the spelling of Naegele's, it also has N there. So just make I'm teaching you this because of adult learning. Sometimes when you don't learn things like that, you tend to forget. But when you remember that, oh, I just said Naegele's pelvis, when you are spelling one, it's O-N-E. Then the Naegele's also start with N. And so then it means one of the ally, when missing, it is called Naegele's pelvis. Now, the Roberts, what will let us remember the Roberts pelvis? The Roberts, we are saying both ally is missing. So when with Roberts, when you remember the word rob, it's like somebody has been robbed of the two things that he's holding. He has been robbed of the two ally. And so hence the name Robert's pelvis. Yes. Is it helpful?
Yes,
hello.
sister.
Yeah.
Hello.
Yes, sister.
Yes, sister.
Because you meet
Very
it somewhere.
helpful.
Yes.
Very helpful.
Yes. You meet it
Thank
somewhere.
you.
And you meet it somewhere so that you don't forget and then you choose the right answer. Good. So that is it. That is for the ally of the sacrum. Now, still at the sides, there are 8 pairs of foramina. 4 pairs of foramina. You see the holes. Please, can you see the holes? There are holes inside
Yes,
the lateral
sister.
side. Yes. They are for the passage of the sacral nerves. They are for the passage of the sacral nerves. Now, when it gets to between the second and third sacral vertebrae. Between the second and the third sacral vertebrae, these nerves will form a tout of nerves. Like if I may use the word a bunch, it will form a bunch of nerves, and then these nerves are known as cauda equina. I'm sure some of you might have heard it. It is known as cauda equina.
Yes.
It is through this cauda. It is through this cauda equina that they give anesthesia, spinal anesthesia, when they are giving spinal anesthesia, because it is between the second and the third sacral vertebrae. The anesthetist, you see, will be palpating the ischia, the iliac crest. Once she locates the iliac crest, she can identify that is where the second and the third sacral vertebrae will be. And that is where the cauda equina is also located. And then she will just introduce the anesthesia to polarize the lower part of the client so that CS can be done easily. Any question? Any question? Please, I'm done with the description of the pelvis. In general, if there's a point I said, I'm not reading the slides. You can see that I'm not using anything. I've taught this for so many years, so I don't have to go to any slide. But then to you, I want to understand that you do understand what I have taught you. If there's a point regarding the sacrum, the ilium, the ischium, tell me. But there was this obturator foramen. Hello, please watch out. The obturator foramen. It is a canal or a passage that is created by the ascending ischial rami, descending pubic rami, and superior pubic rami. So that if in an examination we ask you which of the following structures constitute the formation of the obturator foramen, and I bring any other names, yours is to identify as it is formed or created by the ascending ischial rami, superior pubic rami, descending pubic rami, and superior pubic rami. So that's the superior pubic rami. Then ascending ischial rami, then descending pubic rami, and then you see the whole is created. It is for the passage of nerves, obturator nerves, obturator internus nerves.
Please, only take the description again.
Come again. You say what?
Please, only take the description
go
again,
over.
please.
Okay. Because I said in an examination, that's why you want me to repeat. I'm saying that this hole, it is known as the obturator foramen for the passage of nerves and lymphatics. Okay. And I'm saying that it is created, it is formed by the ascending ischial rami, and that is the ascending ischial rami. Then the descending pubic rami. Then the superior pubic rami. These three structures, 1, 2, then 3, they form the obturator foramen. Is it clear? Is it clear?
Yes, sister. Yes, sister.
Good.
Yes,
Okay.
sister.
On this note.
Yes, sister.
Good. On this note, I want to solicit for your questions. If there's something I said and you are not familiar with, or you didn't understand it, please bring it up. We share with Jojo, come out with a solution. So Asiata Bavia, Asiata Bravia, I can see your hand up. Come up
Yes,
with
please,
whatever
ma.
is bothering you. Go ahead.
Please, I didn't get the ilium, the description of the ilium.
The ilium. Okay,
Yes,
please, whoever got the description of the ilium, please kindly go over it for me. Anybody at all, whoever is conversant with the description of the ilium, that she didn't get it well. Let's hear from one of you. The ilium. Yes, madam.
Please, the ilium forms the upper 2/5 of the innominate bone.
The upper 2/5 of the acetabulum.
Acetabulum, yes, sorry.
Good.
And then the inner part is concave.
Good.
And then the outer is convex.
Good. So the inner part, excuse me, is concave, and it is for the attachment of the iliacus muscles.
Yes,
it is for the attachment of iliacus muscles.
Yes.
Then the posterior, go ahead.
And the posterior is convex.
And for the attachment of
the gluteal muscles.
Gluteal muscles. Good. Go ahead.
And then the ridge is called the iliac crest.
Good.
And then this is called the
which one is called? Hey, which is the illegal? The police CID will come for you to say illegal.
Okay, I'll pause here.
Pause before you commit something. I see illegal. Yeah, somebody should continue for me. I like that. Thank you very much.
Sister, please.
Yes.
Anterior superior iliac spine.
So she's saying that the iliac crest terminates or stops or ends anteriorly to form the anterior superior iliac spine. And then we said about 2.5 centimeters below it is the anterior inferior iliac spine. Then posteriorly, and the posterior one. And the posterior one.
Superior iliac spine.
Good. Then
inferior
inferior iliac spine.
Good. Then we talked about the iliopectineal line at the lateral side of the ilium. The one who asked the question, I hope you are paying attention.
Yes, please.
Good. So we said there's a ridge of bone here, which is called the iliopectineal line. And we said most of the transverse diameter of the pelvic brim is taken between this iliopectineal line. Then we also mentioned that the iliopectineal eminence, which is found in front of the iliopectineal line. So that if I should ask you, which of the following structures lies immediately after the iliopectineal line? And then I'll bring the sacroiliac joint, what, and then if the iliopectineal eminence is there, straight away, that is the answer. And that's anatomy for you. Okay. So that is the iliopectineal eminence. We said the iliopectineal eminence is a thickened portion. It's a thickened portion that can be found immediately after the iliopectineal line. And that its function is to prevent morbid penetration of the head of the femur through the acetabulum. This is what we said about the ilium. Okay. Any question? The one who asked the question, have we answered your question?
Yes, please, ma'am.
Okay, that's good. Now, Sumeya Abubakari, I can see your hand up. Sumeya, Angela Opoku, please speak in this way.
Yes, sister, please. Please, sister. Hi.
Those
Who is
on the
making this
motorbike.
noise?
Hello? Those on the motorbike.
Please, my question is,
Hello, Aja.
Yes, yes. Somebody is on the floor. Your question is what?
yes, it's about the ischial tuberosity. I didn't get that area. Well,
You. Then we'll finish the pelvis today. Please, those who had the ischial tuberosity, the ischium. Is it the whole ischium or the ischial tuberosity? Because the way I'm taking my time to go through this one by
please,
one.
it's only the ischial tuberosity, not the whole ischium.
Oh, okay. The ischial tuberosity. I said it is the thickened, irregular portion. This is it. Of the ischium, upon which the body rests when sitting. That's what I said. The body sits on the when you are in the sitting position, you are sitting on your ischial tuberosity. And the ascending ischial rami continues with it. And then we have the ischial spines, which separate the greater and lesser sciatic notches.
Okay, thank you.
That's all that I said. Okay. On these notes, the description of the pelvis is over.
Aja, please, I have a question.
Ask me, madam.
Please, the ilium.
The
if I
ilium.
get it wrong, said yes. You said it form upper. Is it upper to third or upper to fifth of the acetabulum?
Upper to fifth. You know, we have divided it into, it's like 5/5. The ilium is having 2/5, but it's the upper portion. The ischium is having 2/5, but it's the lower 2/5. And then the pubis, small pubis is also having 1/5, but it's the lower portion.
Thank you.
You're welcome, madam. Okay.
Adia.
Yes, madam. Yes, go ahead.
Can you please the diagonal conjugate? Can you the pelvic to can you explain it to us?
Go. Come on, your sisters. Come.
You said, can I do what?
Use the pelvic to teach the diagonal conjugate.
Okay, I like it will come under the measurement of the pelvis. We are left with 15 minutes to move to labor. So once you have mentioned it, shall we quickly go through the measurement of the pelvis? We can use this 15 minutes to finish with it. So the diagonal conjugate will be part of the measurements. It's one of the measurement of the pelvic brim.
Shut up.
Shall we go through the measurement of the pelvis?
Yes,
Ladies and gentlemen.
Please, can I talk?
Yes, you can. You can. Go ahead.
Please, sisters, if you are not on the floor, if you have not been called by Haja to talk, kindly make sure that your audio is on mute. Eh? The background noise is not even making the lesson interesting for some of us. Meanwhile, Haja is really doing well for us. Thank you.
You want to go to church, Abby? And that
Imagine.
I think I looked at that.
The co-host, can you mute all of them? But when you mute them too, they want to ask questions. And what you are doing is no. Oh, you started well, but look at what you are doing. The August group, they don't do that too. They try to comport themselves very, very well. And the course rep will shout them down.
I didn't think. Wow.
That's why Rahel, can you unmute your mic and stop disturbing the class?
I'm trying to see if I can send her to the waiting room. That is what I'm trying to do because they are not complying at all. When they are there too and they can't get the distance. When anything appears in the exams, they will flop. They will be referred, and then I have to go and prepare another question for them. All these things, I'm considering them, but they are not considering anything. They are not considering anything. My concern is you are doing other administrative work and you have to stop and go and prepare questions for students to write because they have been referred in anatomy. Or they don't consider that they can be referred. If you don't pay attention, I'm saying all this, I've taken my time to go through them for you to, I've come down for you to understand. But if you're not trying to comply, why do you have to do that? It's not easy to teach, so please. Okay. Whoever is making it, I'll put the person they want to. Don't worry. Okay. So the measurement of the pelvis. Please, let's pay attention. The measurement of the pelvis. The pelvis, first the division. The division of the pelvis. We have the brim, the cavity, and the outlets. And the structures that constitutes the formation of the pelvic brim are when you start from the promontory of the sacrum, when you start from behind, from the posterior aspect, you have promontory of the sacrum. I hope you can see. Promontory of the sacrum, the ala of the sacrum, the sacroiliac joints, iliopectineal line, iliopectineal eminence, superior border of the pubic rami, superior border of the
Sister, please,
superior
we
pubic.
can see.
You can see.
Yes, sister.
Can you now see?
Yes, sister.
Okay. Superior border of the pubic, of the superior pubic rami. Then the posterior aspects of the pubic bone. They constitute with similar structure at the opposite side. These structures constitute the formation of the pelvic brim. And I've already told you that the pelvic brim is also known as the door or the inlet of the pelvis. Take note of that. So that is the division. The boundaries of the pelvic brim is what I've told you. The boundaries I'm going over the boundaries. So if I ask you with a well-labeled diagram, describe the pelvic brim, you should be able to mention the structures that form the pelvic brim. You have posteriorly, it is formed by the promontory of the sacrum, the ala of the sacrum, the sacroiliac joints, then the ala of the sacrum. This is the ala of the sacrum, the ala of the sacrum, the iliopectineal eminence, then the superior border of the superior pubic rami, then posterior aspect of the pubic bone. Round. So the brim is almost round in shape, except where the promontory of the sacrum, projects inward. Other than that, the brim is almost round in shape. Please, the slide is there. What I'm telling you, when you go through the slide, you see the same thing over there. Yes, please come in. When you go through the slide, you are going to see the same thing over there. Thank you. You. Hello. Hello. Are we together?
Hi. Yes, sister.
Good.
Yes,
Good. So
yes,
that is the brim. And then the cavity.
sister.
Yes, madam. Good. Thank you. The cavity. The cavity is also formed by these structures. It is formed by the hollow of the sacrum. It is formed by the hollow of the sacrum, the hollow of the sacrum, the greater sciatic notch, the posterior aspect of the acetabulum, posterior aspect of the acetabulum, then the obturator foramen is also there to help with the formation, and then posterior aspect of the symphysis pubis. Please, when you go to the slide, you see the structures for a minute. I don't have it with me here, but at least I'm doing well. Oh.
Thumbs up.
Thank you. So that is the brim, the cavity. Then the outlets. The outlets, it is also shaped like a kite. The pelvic outlet is shaped like a kite. We all know kite. Or it's diamond in shape. A kite is that thing that paper children used to play with it. They add thread to it. It goes up there and they are happy. That is the kite I'm talking about. So that is how the pelvic outlet is shaped. It is shaped like a kite. It is formed by the ascending pubic rami, ascending ischial rami, the descending pubic rami, and then the sacrococcygeal joints. The sacrococcygeal joints, and then what else? The ischial spines. They all constitute the formation of the pelvic outlet. Let's see the measurements, starting from the brim. Please, can somebody help me with the measurements? The measurement. Yeah, help me. Pelvic brim. Good.
The pelvic brim
Go ahead.
posteriorly is made up of the sacral promontory, and then it comes to the sacral ali, the sacropectineal, the sacroiliac joint, and then the iliopectineal eminence, then the superior border of the superior rami, and then the posterior parts of the pubic bone.
Good. Thank you very much. Yeah, you have revised it for me, but then I was asking the measurement of the pelvic brim. That's what I was asking. So if you have an idea, continue. What are the measurements of the pelvic brim?
Sister.
Yes, dear.
With the brim, the anterior posterior is 11 cm.
Good.
And the oblique is 12.
Good.
And the transverse is 13.
Better.
Am I right?
It's left. You are right, madam.
Okay.
That's why I said
and
better.
And the cavity too. The anterior posterior is 12, oblique is 12, and the transverse is 12.
Better. Thank you. Wonderful. The
with the outlet, the posterior is 13.
The anterior posterior.
Yes, anterior posterior is 13, and then oblique is 12. And transverse is, I guess, 11.
11. Wonderful. Clap for yourself. Clap for yourself. You are Beatrice upon Nyakon.
Yes, yes, madam.
Okay, that's good. You have done very well. It's left with some measurements in the brim that you didn't mention. Hello, please let's pay attention. The measurement of the pelvic brim. She did well. Yes, she said the AP diameter, and that is it. Please, can you see? That is the anterior-posterior diameter. The anterior-posterior diameter of the pelvic brim measures 11 centimeters. It is taken from the promontory, the center of the promontory of the sacrum, to the posterior aspects, of the symphysis pubis, at a point about 1.25 centimeters below the symphysis pubis, behind the symphysis pubis, and it measures 11 centimeters. And that is the measurements that we call the obstetric conjugates, obstetrical conjugates. Okay. Now, she also mentioned the transverse diameter, measuring 13 centimeters. It is measured between the two iliopectineal lines. That is the measurement I'm measuring for you. The transverse diameter between the two iliopectineal lines, and it measures 13 centimeters. Then the oblique diameter from one or right or left sacroiliac joint to the opposite iliopectineal eminence, and it measures 12 centimeters. So that is the measurement of the brim. But there's another important measurement of the brim. There are two. The other one, the measurement is taken from the center of the promontory of the sacrum to the opposite iliopectineal eminence. Please watch it. I'm using this thing to demonstrate. It is from the promontory of the sacrum to the opposite iliopectineal eminence. And it measures 9.5 centimeters. It is known as the sacrocotyloid dimension. It is known as sacrocotyloid dimension. Please take note of that. It measures 9.5 centimeters. It is this diameter that the fetus utilizes when it is entering the pelvic brim. So let me demonstrate for you. That is the fetus. You see this big head. It's coming to enter the pelvis. It goes obliquely like this. It enters in oblique manner. And the diameter that it uses is the sacrocotyloid dimension. That measures 9.5. So that in relation to midwifery, Salifu, Ashika, do you want to go to the, what do you call it? The waiting room with your noise? Okay. I won't consider you. She has muted herself, like you see. So I'm saying that, please pay attention and see the importance of the measurement of the pelvic brim. I'm saying that the sacrocotyloid dimension is taken from the promontory of the sacrum to the opposite iliopectineal eminence, and it measures 9.5. If for some reason there's a projection, if the promontory of the sacrum protrudes too inwardly, we said when I was describing it, I said it will reduce the AP diameter. It will reduce the anteroposterior diameter of the pelvic brim. This time, it will reduce this oblique diameter of the pelvic brim. And what the baby does is that if the promontory of the sacrum is too much, baby will do what we call anterior rocking movement. Please listen attentively. Baby's head will be rocking over the iliopectineal eminence. That is the anterior obliquity, anterior rocking movement. If it is not able to enter the pelvic brim, it will turn posterior. Then it will be rocking the parietal bone over the promontory of the sacrum in an attempt to enter the brim. In an attempt to enter the pelvic brim. Now, if it continues doing that, if the baby continues to do that, what happens is that the V that we did and the baby was coming with the vertex, with the occiput. Now, baby's head is not entering the brim well. So what the baby will do is, then let me extend my head. Let me extend my head to see if I can enter this bony pelvis. So baby will extend the head, and then the vertex that you were feeling on vaginal examination, now it is now face presentation. It has turned into face presentation. Then this is where the inexperienced midwife. The VE that she has been doing every 4 hours and was feeling the occiput. She was feeling the posterior fontanelle. Now she put the hand there, and the hand enters the baby's mouth. Baby starts sucking. You know, babies, anything that enters the mouth, it will suck. So baby will start sucking. The midwife, because of inexperience that she becomes frightened. My goodness, Jesus Christ, something has bitten my hand. Then she raise the hand like this. Something has bitten my hand, my hand. Now she will say it has started paining her. Please, let's do away with this superstition. If you are learning this, why can't you apply it? Oh, I was feeling the fetus, but now it's like my hand is in the baby's mouth, it is sucking my hand. That is the experienced midwife. Baby is sucking on my hand. Then it means the whole thing, the whole presentation has turned into face presentation. Let me see where the mentum is pointing. Is it pointing posterior? Is it pointing anterior? So that we prepare for CS. For all you know, but the cervix has dilated probably even at 8 cm. But it will turn into a different thing. All because of protrusion of the mother's promontory of the sacrum. And then the protruding of the iliopectineal eminence, reducing the sacrocotyloid dimension or diameter. Any question? Any question?
Hello.
No, please.
Okay.
Hello.
Then let's come. Hello, madam.
Yeah, sister, please, I'm begging, take it again from where the baby's head touches before the face presentation.
Oh, I said that baby initially was coming with the occiput pointing anteriorly, the vertex, which every midwife wants to see, and it's good. But then because the head has become arrested between the promontory of the sacrum and then the iliopectineal eminence, baby cannot enter again. So it will be rocking the parietal bone, this parietal bone. It will be rocking it over the promontory of the sacrum. And that is what I said is called posterior obliquity. Baby will try that and it's not entering still. It will come to do what we call anterior obliquity. It will be rocking movements using the anterior parietal bone in an attempt to enter. But if it is not able to enter, then baby will try to extend the head. It will extend the head this way. So once it extends the head, the whole presentation tends to be face presentation. It will tend to be face.
Oh, okay.
And that's what I said. The experienced midwife will know that the whole labor process has ended something. It has turned into something else. Now it's his face presentation with this big head of the baby. And remember, by that time, because the baby is also tired, fetal distress will set in. So you prepare for CS. Other than that, if you say you deliver per the face, because initially it wasn't face presentation and exhaustion by the baby, you may lose the baby. So just stop and present. Probably a colleague midwife might have even done the FA, the vaginal examination, say, but I did the VE and it was cephalic, and it was the vertex that was presented. Why are you saying it is face? It is face because your hand even entered the baby's mouth and it was sucking. So you can call your other colleague to confirm the vaginal examination. So that is the measurement of the pelvic brim. There's another measurement of the pelvic brim. Please, let me finish with this one and then we'll break for 10 minutes so people will go and wee and then you come back to the classroom. We are in the lecture hall. We are all there. Okay. So another measurement of the pelvic brim is the diagonal conjugate. It is the only measurement of the pelvic brim that is assessed vaginally. It is the only measurement of the pelvic brim that is assessed vaginally. It is the measurement between the promontory of the sacrum and the undersurface of the symphysis pubis. I'm tired. It is the only measurement of the pelvic brim that is assessed vaginally. It measures between the promontory of the sacrum and the lower border of the symphysis pubis. And it measures 12 to 13 centimeters. It measures 12 to 13 centimeters. And this is called the diagonal conjugate. The other day, I told you that everybody should measure your external measurement of the diagonal conjugate before you enter the vagina. So that you use the ruler. Please, this is how you're supposed to be. Let me put the pelvis down. Please watch out. This is my ruler. I'm measuring my diagonal. Me, I've measured my own already. I know it. That since I became midwife, I know it. So this is how it is measured. Remember, the middle finger is longer than the index finger. This one is longer. Everybody's middle finger is longer than the index finger. And so you place the end of the ruler in between the thumb and the index finger like this. And then the measurement is between the ruler and this one, but not this one. So watch out. This is how it is done. The ruler should be in line with this finger. So that if it is 12 centimeters, if it's 12 centimeters that you get, that is your external diagonal conjugate for your client that you'll be examining. Are we together? Do you follow me? So measure it and put it down. So anytime you do vaginal examination, for example, you measure your own and then you get, say, 12 centimeters. So that in measuring the diagonal conjugate, which every midwife conducting delivery should do, you should try to assess the diagonal conjugate. Other than that, every baby that you deliver will be like a baby. Baby will die. It's not good. Measure the diagonal conjugate. I'm doing the VE. Now, I'm making an attempt. I've made an attempt to reach the promontory of the sacrum. But I didn't reach the promontory of the sacrum. My own is 12 centimeters or 11.5 centimeters. If it is 12 centimeters. I didn't reach the promontory of the sacrum. Look at it. I didn't reach the promontory of the sacrum. And so on removal of my hand, I will write, when I wash my hands and dry them, I will say that promontory of the sacrum, that is at the back of the pathograph, promontory of the sacrum not reached at 12 centimeters. Meaning that whoever picks the pathograph will know that that is the diagonal conjugate that you have measured. The diagonal conjugate of the woman. And that is what you said, the promontory of the sacrum is not reached at 12 centimeters. Meaning your external measurement is 12 centimeters. And you did not reach the promontory. It means that the AP diameter of the pelvic brim is adequate. It's adequate. And the woman can deliver per vagina. By then, if you enter, then as soon as you enter, your hand will meet the promontory of the sacrum. Then quickly, when you remove your gloves and then wash, you write promontory of the sacrum.